My name is Diana Isaacs. I'm an endocrine clinical pharmacy specialist at the Cleveland Clinic, and I'm very excited to be speaking to you all today about update on diabetes medications for the podiatrist. And I'll dive right in. These are my disclosures. And then in terms of the learning objectives, hoping to accomplish in this next half hour, discuss new data and clinical pearls, especially around the hot drug classes, the GLP-1 receptor agonists and the SGLT2 inhibitors. And then we will describe the link between diabetes medications and foot complications, trying to keep this relevant to all of you. So I like to start off any presentation about diabetes meds asking, well, how many drug classes do you think there are available to treat diabetes? And there's really been an explosion of new drugs over the years. And this is just drug classes, right? Within each class, there can be multiple drugs. And so I've listed them all out right here. There's quite a lot, right? There's biguanides and sulfonylureas and TZDs and DPP-4 inhibitors and GLP-1 agonists, and now the dual GLP-1, GIP agonists and SGLT2 inhibitors. And then some of these less commonly used and known drug classes like the bile acid sequestrant, which can also be used for cholesterol, dopamine 2 agonist, bromocriptine. We usually think of that for Parkinson's disease. We do have one amylin, mimetic, pramlintide, alpha glucosidase inhibitors, tons of different insulins. And then, of course, we can't forget about glucagon used for emergency hypoglycemia events. Why do we have so many drug classes? Well, that is because in the treatment of type 2 diabetes, there's actually a number of drug targets. And this is the famous Ralph DeFranzo's ominous octet, where there's at least 8 pathophysiologic abnormalities. And the more of these that you can target, the better. Some drugs target multiple of these organs, like the GLP-1 receptor agonists. And then others may just target one specific organ, like the SGLT2 inhibitors, which are targeting the kidney, although actually now we know they probably have cardiovascular benefits as well. So the more of these we target, the better. Well, what are we going to focus on today? In terms of guidelines, I thought it was important to focus on the American Diabetes Association standards of care. That's really where we get a lot of our guidance from, although there are certainly other organizations as well. And that would be Section 9, which is the pharmacologic approaches to glycemic management. And then I thought specifically for this audience, Section 12 would also be really relevant. That is the section on microvascular complications, retinopathy, neuropathy, and foot care. But you might be asking, well, what's in it for me with them, right? You're a podiatry group. Why do you need to know about diabetes medications? And so this is where I pulled this out of the guidelines, trying to see where the connection would be. And I found these few statements. So optimize glucose management to prevent or delay the development of neuropathy in people with type 1 diabetes and to slow the progression of neuropathy in people with type 2 diabetes, right? So that seems important, right? Managing the glucose to prevent neuropathy. Near normal glycemic management implemented early in the course of diabetes has been shown to effectively delay or prevent the development of diabetic peripheral neuropathy in people with type 1 diabetes. And then insulin sensitizers have been found to be superior over insulin or sulfonylureas for the prevention of diabetic peripheral neuropathy in people with type 2 diabetes. And when it's referring to sensitizers, in this particular study, it was metformin or TZDs like pioglitazone, but showing that those might be more efficacious in terms of preventing DPN over drugs that may cause hypoglycemia like insulin or sulfonylureas. And also, when it comes to diabetes management, we have this wonderful diagram of the pillars, and it truly is so much more than just glycemic management. That is certainly one of the pillars. You will notice that the foundation is lifestyle modification and diabetes education, and other pillars are blood pressure management, lipid management, specifically using agents that have cardiovascular and kidney benefit. And then doing all of that with the goal of reducing diabetes complications. We also follow our ADA treatment algorithm, and this is the latest algorithm that we've had in place for the last couple of years. It's also done in conjunction with EASD, the European Association for the Study of Diabetes, and basically looking at two different components. On the left side, you ask, well, does this person have any complications like atherosclerotic cardiovascular disease or indicators of high ASCVD risk? Do they have heart failure or do they have chronic kidney disease? In which case, you are going to use agents that show benefit for those populations. Mainly, it's going to be GLP-1 receptor agonists and or SGLT2 inhibitors. On the right side of the diagram, you're really asking one of two things. How much glucose lowering is needed? Do we need a 2% A1C reduction or is it just a little bit? Or would this person benefit from both weight loss and from glucose lowering? And being that 90% of people with type 2 diabetes are overweight or have obesity, most people are actually going to really fit into that second one, in which case using agents with the highest efficacy and very high is semaglutide and tirzepatide, two of our incretin agents. Well, what happened to metformin? Like, where is metformin in all of this? And sometimes it gets forgotten, but it still is very much there. And it usually is still first line. And why is that? Because it's been around forever. It does have longstanding evidence. And it's also very cheap. And we know that our newer agents are often not so cheap and not so easy to get. And the reality is usually we're going to be using metformin plus another agent in most people. So the next class that I want to talk about is the GLP-1 receptor agonists, as well as the GLP-1 slash GIP receptor agonist. And how these drugs work, it's really very beautiful. They have like four mechanisms in one. So they stimulate within the pancreas, they actually stimulate insulin secretion in the beta cells, and they also suppress glucagon secretion in the alpha cells. So you might be thinking, well, wouldn't they be expected to cause hypoglycemia? But fortunately, they're not, because this is all done in a glucose-dependent way, meaning when glucose is high after eating a meal, there will be more insulin secreted. If someone decides to skip lunch, no worries, it won't secrete insulin. And in that way, it's very different from a sulfonylurea. But it also directly decreases appetite within the brain, promoting satiety and often causing a person to eat less. And it slows gastric emptying, which helps with that postprandial glucose rise and also helps a person to feel more full. And so in doing all of this, it lowers both postprandial as well as fasting glucose levels. Although longer acting agents like the weekly ones are more likely to have more of that pronounced impact on the fasting glucose levels. And then some people wonder, well, what's different, GLP-1 versus GIP? And these are both incretins. GIP is actually the glucose-dependent insulinotropic polypeptide and often is in the same places that you see GLP-1. But it is hypothesized that there are a few additional mechanisms, such as more pronounced impacts on eating, on promoting satiety, as well as more of an impact on insulin sensitivity. There seems to be some impact on pro-inflammatory immune cell infiltration. And so this may explain why there's some additional weight loss, and there's also some more pronounced A1C lowering with tirzepatide as compared to, for example, other incretins, GLP-1s like semaglutide, dulaglutide. This is a summary of all of the different agents that are available. This actually comes from Beverly Tomasian. She teaches a course. I'm fortunate to co-teach with her, but these are available for free on her website, diabetesed.net. And this is showing the dosing of each of the GLP-1 agonists as well as tirzepatide. Most of them need to be titrated up, which is done either weekly or monthly for the longer acting ones. And then in terms of side effects, the most common side effects are going to be those gastrointestinal, things like nausea, diarrhea, potentially vomiting. Some people experience constipation. Now, when it comes to cardiovascular outcome trials, this is where they've really done very, very well. and especially certain ones like semaglutide, liraglutide, have actually gotten the indication, dulaglutide have gotten the indication to lower the risk of 3-point MACE, so major adverse cardiovascular events, things like heart attacks, stroke, and cardiovascular death. And this is a meta-analysis just showing that when you combine all of the big cardiovascular outcome trials together, that it is favoring the benefit of GLP-1 agonists. And this was all done without increased risk of hypoglycemia, retinopathy, or pancreatic adverse effects. So because of their positive cardiovascular outcome trial, many of them have gained that indication to actually decrease cardiovascular risk. 3 of them have the indication to actually use in pediatric patients ages 10 and over, because we're certainly seeing a lot more younger people being diagnosed with type 2 diabetes. And then we have 3 agents, that's Ozempic, Victoza, and Mounjaro, or I'm sorry, actually semaglutide, which in the form is Wegovy, liraglutide, which in the weight loss form is Saxenda, and then tirzepatide in the weight loss form is Zepbound. So they have different names, even though they're the same molecule. Those all have specific indications for weight loss. In the case of semaglutide and liraglutide, they go to a little bit of a higher dose with those. And with tirzepatide, it's the same max dose of 15 milligrams weekly. Now, there may be some new indications on the horizon. There's been a lot of exciting new data. In the case of semaglutide, that's recently been studied in diabetic kidney disease in the FLOW trial, showing benefit for people with type 2 diabetes and kidney disease. So previously, SGLT2 inhibitors were always like that first-line drug of choice in kidney disease. We may see that change. Also, similarly, SGLT2 inhibitors have always been the preferred for heart failure. And now we've seen that semaglutide, when used in people with overweight or obesity, actually had positive benefits in heart failure with preserved ejection fraction. And then recently, tirzepatide was studied for sleep apnea, showing benefits, and that may be a new indication on the horizon as well, even irrespective of having diabetes. So a very exciting time. You are bound to see more of these drugs used in your patient. Now, Daniel Drucker, he's amazing. He just spends all of his time studying different incretin agents and is very well published and shares a lot of his insights on social media, on Twitter, and it's just wonderful. But this was a recent review article that he wrote, and I love the images in here and showing, okay, when it comes to GLP-1 medicines, where is the evidence right now? And certainly there's evidence it reduces A1C, it's treating obesity, also reducing major adverse cardiovascular events, kidney disease, heart failure with preserved ejection fraction, decreasing cardiovascular death. There appears to be established benefit in terms of kidney disease, like treating or post-MI, stroke benefit. And then where are some of these that we're investigating? Definitely for fatty liver disease, Alzheimer's, they're looking at that, peripheral arterial disease, Parkinson's disease. So we likely are going to have different indications, or at least different studies coming out in the future. And when it comes to these adverse effects, there's some that have been very well established. So that's what you see in the red there, like the GI side effects. There's been links, for example, with worsening gallbladder disease, and acute kidney injury can occur, usually related to dehydration. Possible adverse effects in terms of things like sarcopenia, neuropsychiatric events have been reported. And then what's probably pretty doubtful, it seems like the initial links with retinopathy, with thyroid cancer, pancreatitis, we're starting to learn that's probably not necessarily related directly to the drug. All right, so that's the incretins. The next I want to talk about are the SGLT2 inhibitors. And the way these drugs work is they are inhibiting the SGLT2, and that is where 90% of glucose is actually reabsorbed. So in doing that, they're causing more glucose to be excreted through the kidneys. And about 10% is SGLT1, but these are mostly inhibiting that SGLT2. So it's decreasing the renal absorption. There are almost six drugs in this class. So the five are listed right here. They're all Flozins. They're all generally dosed once a day orally. And in terms of side effects, the most common are usually those genitourinary infections. We also see decreased blood pressure, and increased urination can occur as well. And when it comes to what are they used to treat, so we've had this series of cardiovascular outcome trials showing the benefits in cardiovascular disease, the benefits for heart failure, benefits for kidney disease. The exception is that ortuggliflozin hasn't across the board been able to show the benefits for everything. For example, renal disease and cardiovascular disease, it doesn't have the indication for that. And then bexigliflozin is one that you can actually get on Mark Cuban's low-cost drug plan for like under $50 a month. So it doesn't really have published cardiovascular outcome data, but it is an SGLT2 inhibitor we're able to get for a very affordable price. And then empagliflozin and dapagliflozin have been studied in patients with and without diabetes, showing the benefit. Canagliflozin has been studied in people with diabetes, and that's kind of how they get their indications based on who it was actually studied with. So also, I did not want to leave out, and this is why I said, well, there's kind of 5.5, because we do have another SGLT2. This is actually a combined SGLT1/2 inhibitor called sotagliflozin. But this drug is really more it's a heart failure drug. It's indicated to reduce the risk of cardiovascular death, hospitalization for heart failure, and urgent heart failure visits in adults with heart failure or in adults with type 2 diabetes, chronic kidney disease, and other cardiovascular risk factors. This is also dosed once a day. And one of the interesting things about this drug is originally it was submitted for type 1 diabetes. There's some data showing benefit in type 1. And my understanding is they're going to be resubmitting it to see if they can get the labeled indication for type 1 diabetes again later this year in people with impaired kidney function. So kind of stay tuned for that. This is available, and so you may have some patients on this drug as well. There is a slew of evidence in terms of all of the cardiovascular outcome data, and that is what's listed here, the summary of the different data. But I wanted to address something. So remember, I'm trying to keep this relevant to you, even though I'm sure you have tons of patients that are on these different drugs. But if you remember, canagliflozin, back when their cardiovascular outcome trial was published called the CANVAS program, there was actually an increase in lower extremity amputations. And this is showing you the difference between canagliflozin and placebo and the hazard ratio of 1.97, which was found to be statistically significant. And the number needed to harm at 5 years was 69. So this is a little bit concerning, right? And when we think about, well, what could be a possible mechanism of action? And this was actually presented at ADA scientific sessions. I thought this was really good, showing, okay, well, people with diabetes may already have some risk for amputations. Maybe they had a prior amputation, or they have a foot ulcer or infection, or they have peripheral arterial disease or neuropathy, or they're smoking, right? You add on an SGLT2 inhibitor to that, and they may have volume depletion, which leads to poor perfusion and then exacerbation of ischemia and infection. And maybe that's the reason that it leads to lower limb amputation. Well, actually, a few different meta-analyses have been done because, of course, if this is true, this would be very, very concerning. And so looking at, okay, all of the other SGLT2 inhibitors, and what do we see? And fortunately, when this was looked in a meta-analysis with 13 large placebo-controlled studies, there was not a greater increase. In fact, it seems that it's really, for whatever reason, this was something found in the CANVAS program. Even the follow-up trial, which was called the Credence, which was done, it was placebo-controlled as well with canagliflozin, but that was done in a population looking at kidney disease. They did not find this increase in amputation. So it's unclear, is this just, do we need to worry about canagliflozin, or was it just kind of a fluke with this first trial? Now, Also, what was noticed in that Canvas program was that there was also an increase in fractures as well. And so this was, in this meta-analysis, they also looked at, is there an increased risk of fractures with SGLT2 inhibitors? And they again found that there really wasn't a significant effect on fractures, and canagliflozin with the Canvas was really the only trial that had that statistically significant increase. Now, that being said, of course, we still want to manage potential risks. And with the lower limb amputation risk, potentially maybe we should pick different drugs other than canagliflozin. It's unclear, but I think no matter what, whatever drug that you're using, the emphasis on preventive foot care. Definitely advising people to check their feet daily, to get their routine foot exams. I think that is really, really key. And also consider holding it during a time where there is an active foot ulcer. In terms of, I haven't mentioned this, but there is a increased risk of DKA, diabetic ketoacidosis, that can occur with these agents. It is more common when used off-label in people with type 1 diabetes, or when using it in people with type 2 that are taking insulin. This is one of the reasons that now our guidance is really to hold it 3 to 5 days prior to some type of planned surgery, and also holding it for acute illness. And I think this is important because normally we don't encourage people to stop taking their medications. But in this case, this is a time where we may want to advise people to do that. And also, if you're going to be starting this and adjusting someone's insulin, making sure we're not decreasing it too rapidly. Normally we say reducing it by 10 to 20%. And another thing to keep in mind with SGLT2 inhibitors is that for glucose lowering purposes, they really only work when the GFR is at least 45. When GFR dips below 45, they still have benefits on kidney function and cardiovascular outcomes and heart failure, but they're not expected to lower glucose. So in those cases, it may not be necessary to adjust any other glucose lowering medications. And then with bone fracture, this again was only seen with canagliflozin, but maybe just considering other factors that could contribute to fracture risk, certainly things like osteoporosis, making sure that that is monitored as well. In terms of all of the other drugs, so there is a very nice summary chart, both in the ADA standards of care as well as the ACE, the American Association of Clinical Endocrinology guidelines, and it compares them in terms of things like efficacy, the hypoglycemia risk, weight changes to expect, effect on MACE, major adverse cardiovascular events, the impact on heart failure, renal, as well as cost. Something to keep in mind is that when it comes to hypoglycemia, really the only drugs that directly cause it are sulfonylureas, so secretagogues like sulfonylureas and glitinides, as well as insulin. All of the other drugs by themselves are not expected to cause hypoglycemia, but anytime you combine a drug with one of these sulfonylureas or insulin, then you can increase that risk. And then the one other thing is cost. So cost with our GLP-1 agonists and our SGLT2 inhibitors, those all tend to be higher cost medications compared to drugs that are generics like metformin, sulfonylureas, TZDs are all much lower cost. Unfortunately, TZDs and sulfonylureas are associated with weight gain. And then DPP-4 inhibitors have just really fallen out of favor. They are very safe to use in terms of they don't have a large side effect profile. They also don't have a lot of glucose lowering, and they don't have cardiovascular benefits. And in fact, when it comes to heart failure, saxagliptin and alogliptin may actually cause harm. And so those have just fallen out of favor, although there's certainly times when we may want to use it, especially if we can't use a GLP-1 agonist for whatever reason, either due to side effects or because the person does not have weight to lose, and we're concerned about losing too much weight and maybe those fall risks and things. All right, so I don't have so much time left, but I wanted to at least touch on insulin because insulin is so important. And we know every person with type 1 diabetes needs insulin to live, and many, many people with type 2 will eventually go on to need insulin because people are being diagnosed so young now, and we want them to live long lives. But naturally, if they've lived with this condition for 30 years, it is likely that they may require insulin. We have a ton of different insulins. We have, you can see on here the bolus types of insulins and our basal insulins, and then we do have some pre-mixed insulins. Everyone with type 1 will be on both a basal and a bolus unless they're on a pump, in which case they will be generally on a bolus insulin that goes through their pump. And then with type 2, we usually start with a basal and then we increase, we may add a bolus type of insulin over time. There are concentrated insulins as well, and this has also gotten more confusing, and I don't have time to dive into all of this, but just understanding that there are concentrated insulins that we may be more likely to use for people that need higher doses of insulin. And we have several U200 formulations now that generally work pretty similar to the U100 formulations. They just hold more insulin in their pens and they create less volume to be injected at a time. We have U500 insulin that's been around for a very long time, and the kinetics of that make it more difficult to work with, but some people require such high doses that we still use that. And then inhaled insulin is probably underutilized. A lot of people don't know about that. That is a rapid acting insulin that serves as a bolus insulin, but it is inhaled instead of injected like all the others. Now, the one thing I really thought it was important to share is weekly insulins. So these are not available yet, but there are two that have been extensively studied and may very well be available in the future. And I think this creates a really important option because we know that taking insulin every day is very challenging for people, and a lot of people don't do that. And then we see some of these complications like DKA or hyperglycemia over several years, which leads to the foot complications that you're all seeing. So I do think this will be a really important innovation. There's two being studied, insulin icodec with is Novo Nordisk insulin, and then insulin efsitora alpha is Lilly's insulin. Both of them have had pretty promising data so far. The icodec was submitted to the FDA for type 1 diabetes and did not gain approval at this time. One of the concerns was just that there was a little more hypoglycemia. And so the thing is, the dosing of this is different. It is more concentrated. So it's actually, at least in the case of icodec, it's a U700 insulin. And so it's going to be 70 units dosed once a week for the starting dose, which would be similar to 10 units, right, a day. But the idea of starting at 70 units sounds like a lot. And so this is something they're going to be resubmitting it. We'll see. Maybe it'll gain approval for type 2. We don't know. And then very recently at the EASD conference, the insulin efsitora alpha had some new data coming out showing a lot of promise. And so I do hope that this is an option in the future, because I can definitely think of some patients that adherence wise would really benefit from it. So stay tuned on that. And so to leave you with a few practice pearls. So meeting glucose targets is the best way to prevent diabetic peripheral neuropathy and foot complications. And that is why this is relevant to you. SGLT2 inhibitors and GLP-1 agonists are preferred medications now for type 2 diabetes because of their positive effects on glucose, but also on weight and also the cardiovascular benefits, and as well as other new indications, things like sleep apnea. Very exciting times. We do want to optimize the use of non-insulin agents before adding insulin in type 2 diabetes, but many people will go on to need insulin. And so there's a lot of exciting updates, both with the incretins, with SGLT2 inhibitors, with expanding indications, but also with insulin, with weekly insulin on the horizon. Here is my contact information, so please feel free to reach out. I'm also on social media. And then I have a podcast that I do with my wonderful friend and colleague, Natalie Bellini. It's called Diabetes Dialogue, and you can find that wherever you find your podcast. There's also a link here if you want to see the video version of it. And I want to thank you all so much for having me today, and I wish you a great rest of your conference.